welcome you both to today's episode of The Beat podcast. I'm pleased to be joined by Martha and Rajat, members of the PACE ID clinic here at Santa Clara Valley Healthcare. And I'm excited to talk with you all today about HIV care in Santa Clara County and the wonderful work that you're doing over there at that clinic. Welcome, and feel free to introduce yourselves and tell us PACE ID. What does that mean?
My name is Raja. I'm the pharmacist at the PACE clinic, which is the Partners in AIDS Care and Education clinic. I've been there for almost 10 years now. So since 2013. At first I was a student there. Now I've been practicing there as a pharmacist in a clinical role. So essentially my role there is a lot like a nurse practitioner's or like a mid-level provider, where I'm trying to focus on medications specifically. So making sure that patients, when they come into care, that we get them started on treatment, and patients who are struggling to take medications for various reasons, that I can help them improve and achieve the same goals that we have. But on a broader level, I work with the clinic at probably the broadest level, trying to make sure that we can get as close to zero new HIV infections in the county as possible. And I think that's the overarching goal of the clinic, is to work throughout the county to minimize new HIV infections, which involves many different initiatives.
Great. So PACE ID, can you tell us what that stands for people who may not know?
PACE stands for Partners in AIDS Care and Education, and then ID stands for Infectious Diseases. So the clinic has both two different services that are offered in the same location, but that are staffed largely by different groups.
Well, thank you for that. And Martha, welcome to The Beat.
Yeah, thank you. I'm Martha. I guess I have been at PACE Clinic for about 4 years now. I initially started as inpatient nurse at the critical care unit, CCU. And I was working extra shifts at the PACE clinic, and that's how I came to find out about the clinic and what they do for patients living with HIV. And I really liked what I saw, and there was an opportunity that came up, and I took it, and I started working there, and I'm glad I did. And we do, as a nurse, my role is to assist patients when they first come referred to our clinic. Usually when patients come to PACE, it's done by referral from their primary care doctor or from the community doctors. And throughout, we set them up with their initial appointments, and also the nurses support them throughout their care, the clinic. We assist clinically during their intake and discharges. We administer medication like vaccinations or STI treatments. We do administer also HIV injectable treatment, which Raja can elaborate on that later. We also we collaborate with the multi-disciplinary team that we have at the clinic, which are social workers, mental health professionals like counselors. We have psychiatric workers as well, or psych doctors. We also have dietitians, outreach workers, and all these, multidisciplinary team works with the nurses. And the nurses, if once they identify issues that are psychosocial issues that need to be addressed, they link patients with these services. And these services are unique to our clinic only, and they are they only support our patients. So that's part of what kind of we do in a nutshell.
All right. So it's a very complex place that you work at, providing a range of services for the many people in the county experiencing HIV infections, other infectious diseases. And so can you tell us a little bit more about what HIV is, how many people that are in the county of Santa Clara that are experiencing HIV positive diagnosis, and the services, then going a little bit into deeper of the services that you provide to care for these folks as well?
HIV, I think in general, people tend to underestimate the incidence of HIV in any area. It's substantially more common than one might think. So, for example, the lifetime risk for getting HIV for a young Latino living in Santa Clara County is estimated to be 1 in 4 if they have sex with men. So I think if you were to ask a young Latino male in the county who has sex with men what the chance of them getting HIV is, they would probably guess that it's much less than 25%. Amongst young African-American men, especially in the southern U.S., we don't have as great data for this county. The southeastern U.S., the risk can be as high as 1 in 2. But beyond the gay community, there's also a lot of HIV seen by just the numbers in the heterosexual community or in people who have more varied sexual or gender identities. So it's a disease that affects everyone, but is particularly high incidence amongst the gay community. And I don't think that's talked about enough. The clinic has roughly 1,500 patients that are actively enrolled in the clinic, but the number of patients in the county that are actually infected with HIV is greater, because there's other HIV clinics, private clinics, for example. I don't know offhand the total number living in the county with HIV, but every year we get about 150 to 200 new HIV diagnoses, and that's been pretty stable over the time that I've worked in the clinic. So although there's been a lot of progress to get people into care and to make treatment simpler, the reality is that we're still not doing an excellent job across the U.S. and within the county at preventing new HIV infections. So that's one area that the clinic is really and the CDC are really focused on. But it's quite prevalent, and it's something that I think people who are sexually active need to be very aware of, that this is a preventable STD that affects a really high proportion of people if they don't do anything to try to prevent it.
So I definitely want to highlight the work that the PACE ID clinic does, but just can you give a quick, summary of what HIV is and some of those risk factors, what it is exactly, this disease?
Yeah, so HIV, in the simplest way to think about HIV is it's an infection that damages your body's defenses. So if someone gets HIV, typically without any treatment, they will lose a part of their immune system that fights off a variety of infections called your T cells. That's what we were seeing in the 90s, the 80s, and the early 2000s. Most people that were coming into care were sick. They had infections in the lungs or they had cancers of the skin, and those would be alarming enough that they would seek care and then be diagnosed with HIV and AIDS. AIDS is essentially the term for HIV that has progressed to an extent that the body's defenses are weak enough now that infections can occur. It's critical to understand that although there are many different ways that people could get HIV, that the vast majority of infections are spread through sex or through sharing of needles during injection drug use. And the type of sex makes an enormous difference. So the risk for getting HIV from receptive vaginal intercourse is much, much lower than the risk for getting HIV from receptive anal intercourse. So for example, in a low-risk sexual setting, the risk might be 1 in 1,000 per act, whereas in a higher risk setting, for example, during receptive anal sex, the risk can be, in some studies, as high as 1 in 70. And there are factors that can increase the risk beyond that. So a lot of times people don't really think about the type of sex they're having and how that might affect their risk for different types of STDs. So, that's something that I think there needs to be a lot more education about so people can make informed decisions about their sexual health. But in a nutshell, HIV is a sexually transmitted infection that, if left untreated, will just completely decimate your immune system over a period of years. So this isn't like an infection that people will usually feel. Most people who have HIV, they don't feel anything other than maybe like they feel like they had a cold for a few weeks. And then their body starts to handle the infection, and a long, slow, years-long struggle between the body's defenses and the virus begins. And that can go on for, in some cases, a few months before there's a collapse of the immune system. In some cases, it can be decades. So a lot of times people don't think that they're sick because there's nothing that they feel. And so this is where really the only way to reliably prevent and to be sure you don't have HIV is to get regular HIV screening. This is why HIV testing is so important, because unlike COVID or the flu or other STDs like gonorrhea or chlamydia, you typically won't feel anything that alarms you. It's very easy to deny that there could be something going on.
I think I saw somewhere that there's somewhere over 3,000 people in this county that have HIV positive results.
Yeah.
And you said you're seeing hundreds of people coming into the clinic, a few hundred each year. So what is the process like for the PACE ID clinic when someone comes in, they've tested positive? How does your clinic begin to care for this patient?
So patients, when they come to our clinic, they have already been tested and they have already tested positive. We don't do the testing, but they should have been tested previously before they get referred to us. The referral process usually is we get from public health department, like as a rapid start. We get referrals from primary care doctors within the community. And once our infectious disease doctor evaluates the patients and then the clinic accepts them, we start the process of the initial consult appointment with various care providers, pharmacists, and also medical doctors. We also link them. We try to treat not only the actual infection medically, but also try to address and identify issues that they may have socially and also psychosocially, I should say. This is because initially when we start therapy, we highly rely on their compliance to care and adherence to care and on their ability to maintain that care. So our outreach team, social work, mental health team tries to address that with the initial appointment.
Yeah, I think what I'll add to that is that if you imagine yourself being diagnosed with HIV, because there's so much stigma and fear around the diagnosis, it's very different than being diagnosed, say, with high blood pressure or diabetes, even though the medical implications of HIV may not be as severe as something like diabetes. But it's an overwhelming diagnosis. Like you'll hear people say HIV or cancer, they're lumped together like these life-changing diagnoses. Whereas cancer often is a life-changing diagnosis, HIV doesn't actually have to be. But as with many things, if you're terrified by a diagnosis, you're much less likely to seek care for a host of reasons. I mean, it may just be that you're not able to handle the diagnosis or you're overwhelmed or some element of denial kind of creeps in. But there's also more sort of obvious pathways that lead people not to link. So a lot of our patients who are being diagnosed with HIV are struggling with other issues in their personal life. Often they're struggling with homelessness, addiction, psychological issues are often present. We see a lot of patients who are really struggling with their mental health. And so if you can imagine in that circumstance, like if you're struggling with meth addiction and homelessness, and then you're told that you're HIV positive, that may be overwhelming, and you may find that you're all of a sudden using a lot more, which obviously makes it that much harder to successfully schedule an appointment and link to care. So a lot of what we see in terms of, how is it that people get diagnosed, find out they have HIV, and then never end up getting undetectable or controlled on medications, a lot of it is that actually that initial few weeks after diagnosis is what exactly happens in those moments. And then to make it even more important, almost all HIV infections are spread by people within the first month or so of their infection. So when you're first infected with HIV, you have a very, very high level of the virus because your body isn't doing anything to treat it. Your body doesn't know how to treat it. And as time goes on, your body starts to make antibodies and the level of the virus goes to a much lower point where you're much less contagious. So the clinic is focused on what Martha kind of mentioned, which is rapid start, as are all clinics really in the U.S. at this point. The idea is that when someone finds out, when they test positive, that a series of resources are activated for them as soon as possible so that they're not just told, you have HIV, you're going to get some phone call with more information, just wait for that. you don't want someone to go home and then become suicidal or, go into denial. So instead, what's typically done is, if possible, they're linked to a public health social worker who then is there as a liaison and a navigator so that they're not alone in the process. And the social workers that we have at public health are really excellent. I mean, they're truly excellent, and they have the most experience of anyone that in the clinic or not that we know of in terms of helping patients navigate that initial diagnosis. So they will then contact me or someone else at the clinic, and we'll start the patient, if it's safe to do so, which it usually is, on medications as soon as possible. I mean, and ideally within days of the diagnosis, before they've even received results of like other blood tests or things like that, so that the patient can feel some agency. Like, I'm not just HIV positive, I'm HIV positive, I'm on treatment, I'm taking care of this, I'm going to be okay. Versus like, I'm positive, I don't know what's going to happen. How am I going to get through this? They need that support immediately. So I think that's really where our intake process is sort of focused on that particular problem.
Okay, so that's kind of the beginning stages when somebody comes to you having tested positive for HIV. It's incredibly important work because, like you said, there's many people coming to you each year, as well as some other risk, or rather challenges that you face, because sometimes people don't know and they are spreading it because, like you said, they have a higher rate of the disease in their body. What are some of the other challenges, whether that be from a medical standpoint, a social standpoint, in getting the care that people need, while also knowing that there is currently no known cure for HIV?
I think it's important. There's a lot of little challenges. There's a lot of medium challenges, but there's one huge challenge, which is stigma. If you were to just eliminate stigma from the HIV equation, it would look a lot like the challenges you see in getting patients to, say, take their blood pressure medications or take their diabetes medications. The challenge is that people don't want to accept that they have HIV, because it means in many cases that they're going to be treated very differently, or they perceive that they'll be treated very differently by their loved ones, by their families, by their communities, by their employers. I do think that in this county, especially in communities that see more HIV, like in the gay community, that there is more acceptance and understanding than in most places in the US, and that most patients actually find that if they're open about their HIV diagnosis, that they get more support and love than they do hate. But still, managing to get to that point where you stand up for yourself and express who you are can be, is not always an option. It's not something that everyone's, supported enough to do. So stigma being sort of the main issue, I think you kind of also have to look at like what tends to happen, what tends to lead patients to getting HIV. So most of our diagnoses are in their mid-20s, typically like 23 to 27. As I mentioned, like the per act incidence of getting HIV is actually not that high. It's not like having someone who in the same house with you as COVID. So people tending to get HIV, 5 to 6, 7 years after becoming sexually active, rather than like right away. And we tend to see that a lot of our new diagnoses are coming in with issues related to housing, issues related to mental health, so that there's enough stress and chaos in their life that they're not receiving the support they need to focus on prevention and sexual health. So, but by and large, we're dealing with young, healthy men who don't have major medical issues. The other side of the HIV coin is that we have a lot of patients who have been living with HIV for 15, 10, 30, for a long time. And HIV is much more than just a disease that affects your immune system. So one way to think about it is that because you have a lifelong infection, your body is constantly trying to get rid of that infection. And that process happens whether you're on medications or not. So the process that the body uses to get rid of an infection is inflammation. And inflammation, as we know, drives so many of the chronic medical conditions that we have: heart disease, cancer. All of these diseases are at their heart inflammatory diseases in many cases. So for a lot of patients, we might say that like smoking a pack of cigarettes produces a degree of inflammation in your body, and you can see all the negative consequences. That having HIV is somewhat similar to that, even if you're on medications. That being said, I think it's really important to reiterate and to understand that HIV by itself, a diagnosis of HIV doesn't affect in any substantial way one's life expectancy. So newly diagnosed HIV positive individuals, although their risks for heart disease and cancer go up significantly, the chance that they actually have an event that leads them to mortality is not dramatically increased like it was in the 80s or the 90s. And that's mainly because they can be on medications that can help to minimize that risk for progression to AIDS or that degree of inflammation that they get. But it's really important for people to understand that, because the thing is that like if you think back in your own life, you can probably think of like an old grandparent or someone in their 90s who smokes like a pack a day and drinks like 3 wine glasses of gin, and they're fine. And a lot of people use that in their mind to be like, oh, it's okay. Like, I have strong genes, I can handle it. The difference is that with HIV, you're starting at a point where you already have a lot of stress on your body. So people with HIV who smoke cigarettes, for example, lose on average something like 7 to 10 years of life, versus people without HIV who smoke lose a few years of life on average, 1 to 2. So your risk is amplified, and the chance that you kind of go over the threshold and fall off that cliff, get a heart attack, get a stroke, develop cancer is just that much higher when you have HIV. So we see comorbidities related across the whole spectrum. I mean, that patients with HIV have to be concerned about their physical health, their cardiovascular health, their cognitive health, their orthopedic health, all of those things, in ways that people without HIV do not at a young age.
One of the challenges also is patients, that we see a lot of patients that have challenges of being new to the country, seeing a lot of immigrant patients, non-English speaking patients, so having barriers to employment, language, barriers to maybe not being able to pay for their coverage. So those are also other challenges that we see once the patients come to our clinic.
So one thing that we do a lot of in the clinic, we have insurance workers, but we also kind of everyone that works in the clinic thinks, I think, in a way like a case manager. It's like, how can we navigate this patient, as if they were our child or our grandparent? How do you get them, into care? Like, what are the actual barriers? In some cases, it's like a patient may have, a $3,000 a month cost that they can't afford. In some cases, they may have to use they have an HMO and they have to go to some particular clinic that they don't know how to get to, or that they don't feel comfortable going to for various reasons. There's all sorts of barriers that people run into. Fortunately for us, those barriers tend to be reduced for patients who are low income, because of the essentially socialized, as close as we have to socialized care through Medi-Cal. That actually works really well. It's often our patients who are working, but they don't have insurance through their employer. They're sort of underinsured, or who have like a decent income, but not enough to afford, all of a sudden like an additional cost of living. That those are the ones that we often have challenges with. And so the clinic has worked kind of really hard to figure out pathways to help everybody, no matter what their situation is. But even then, like there's cases that are just mind-boggling in terms of like how hard it is to get therapy started, just from a logistical standpoint with insurance and the different networks and pharmacy benefit managers that are out there.
When you talk about the work that you do at your clinic as far as destigmatization goes for people living with HIV, how does that help in also a medical treatment sense? Because ideally, yes, we want to help in that psychological sense, where people don't go home and have suicidal thoughts and become isolated. Does destigmatization also help with the actual medical treatment of these cases as well?
Destigmatization is a critical part of the medical treatment. If you think of medicine from a textbook standpoint, perhaps it doesn't matter. But if you think about medicine from a behavioral standpoint, which is what I would encourage everyone to do, it's really, really important, right? If someone doesn't feel comfortable taking a pill every morning because it reminds them they have HIV and they don't want to deal with that, it doesn't matter what pill you prescribe them. They're simply not going to take it regularly. So like, for example, when I see a new patient, or when I'm training students or residents, like we always focus in that initial visit at really trying to break down stigma. So it's letting patients know that, yes, they can have kids and the kids won't be positive. Yes, like you can have sex again. You just have to be undetectable. It's normalizing this. Like, this is a medication. It's really not that much more complicated than, say, taking ibuprofen or iron or a birth control pill. Like, these are simple medications. They're not dangerous. You're not going to overdose on them. You don't have to take them like clockwork, with or without food. Trying to help people understand that it's simple, and that really the challenge is on accepting the diagnosis, talking to people about it, getting help from counselors if you need that, and not trying to focus them so much on like the medical side of things, but really on like the moving forward, the psychological progression. But I will say that the treatment options that are out there kind of also give us some ways to help people with stigma, in that like a lot of people are just really afraid of other people finding out, right? Especially initially, if no one knows, you're kind of dealing with this all by yourself. Now we do have some options where like the patients can get their therapies entirely in the clinic. So we will often ask patients like if they'd rather have a shot than a pill, which for patients who don't want to deal with taking something at home, maybe they live with people that don't know, that's an option where they can come into the clinic once a month or every 2 months in some cases to get HIV treatment. And they can feel very private about their diagnosis. So we're always looking for ways to sort of reduce stigma and help patients on the very individual level, work through stigma so that they can feel confident in their ability to survive with HIV.
So I'm sure it's different from case to case, but we've talked a little bit about the intake of when somebody becomes HIV positive. They come in and they meet with you all, and you get hooked up with counseling and social workers and things like that. Can you talk a little bit about then the ongoing treatment that people go through? And is this something that they're coming in, I guess, how often? Is this for the rest of their life? What is the trajectory of those patients that you see coming in after the initial intake?
HIV, it's an interesting question, actually. If you look across countries, you'll see totally different models. The U.S. healthcare system tends to be more intensive. We want more visits, we want more labs, we want more essentially billable events, right? So there's this problem of like our medical system has evolved around billing for individual procedures rather than billing for like the outcome in the community. So you don't get paid as a clinic or as a hospital system directly for the outcome, rather it's for the individual steps. And so in the US, current guidelines still recommend that patients with HIV are seen at least every 6 months, that they're doing lab tests typically every 3 to 6 months to check their viral levels. And in some cases, some insurances are still requiring patients to have their T-cell count, which is a measure of their immune system's strength, done every 6 months as well. A lot of this is based on history, right? So if you go back to the 80s, to the 90s, to the early 2000s, when the therapies weren't as good, a lot of the drugs themselves would cause problems that needed to be monitored. So for example, there might be something wrong with your liver or your kidney, but you don't feel that until, and so a blood test would maybe help avoid problems later on, because by the time you feel it, it's much more advanced. The drugs also didn't work as well. So just taking the pills every day wasn't a guarantee that they would work. Whereas now, the therapies that we're using, if patients are taking them with greater than 90% adherence, they're not failing, unless there's some very unusual circumstance to begin with, like they came in with extensive resistance to medications, which is exceedingly rare now. So, in the past, we'd be telling patients, like, if you go back 10 years, 15 years, the thought was, well, if you miss doses of your medication, they may stop working, or even if you take them all the time, like, we're going to save these other therapies for you in the future when you'll need them. Whereas now it's much more like other disease states where the drugs that we're using, they're going to work. They're easy to take, and they don't really cause. They're not expected to cause significant problems with liver or kidney. So the need for monitoring is somewhat less. As a clinic, I like to make sure that the patients are getting their labs done at least once a year. And a lot of this is individualized. So like a patient who is more medically complicated, they may need to do their labs more frequently. But a patient who's healthy and busy and doesn't have a lot of time, like we try to keep things as easy as possible, right? I mean, the real goal is to get them to take their medications, control their HIV, not spread the infection, and be able to live like a normal, healthy life, not to have them come in and do lots and lots and lots of testing if we don't need that. But basically with a new patient, what I'll tell them is like, you've just been diagnosed. We're probably going to have you try to come back into the clinic within the next month to review all the blood tests that you've done, to go over your vaccine history to make sure that you're not going to get anything else, that we can prevent everything that we can prevent. And then as time goes on, things are going to space out to being roughly like an every 6-month visit in the clinic, which could be done over the phone, for example. So a lot of the logistical complexity for the patient will kind of taper down to being just, a phone call every 6 months, going to the lab once a year. And we try to have the pharmacy mailing or delivering medications. Patients don't usually have to call. They're usually going to be getting the pharmacy doing all that work for them. So the pharmacy will be calling them every month or every 3 months to mail it. So the idea is the least amount of work possible from the patient so they can focus on the parts of the life that are more important to them and should be more important to them, like taking care of their mental health, their financial health, their families. And, we're there to support them, but not to overwhelm them.
Yeah, I think a lot of our patients, when they first get diagnosed with HIV, most likely they don't have a primary care physician, so they don't get primary care. And when they come to see a HIV specialty doctor, that's when they may decide to find a PCP on their own, or they may decide to stay with us. But a lot of our patients are in fear of stigma. If they seek medical care somewhere else, another facility, another clinic, or a primary care physician, they're comfortable with us, seeking care with us for all aspects of their healthcare needs, instead of going somewhere else where they are not known, where their status is not known, and feeling the stigma and the isolation. So a lot of our patients, although they get their HIV care, they also get their primary care from our clinic. Wonderful. So it's a more compounded care that we provide.
Yeah, and that's actually pretty unique. And if you look across the country, there are very few HIV clinics that are still doing primary care. Most HIV clinics are primarily infectious disease clinics that treat HIV as part of their infectious disease practice. So like if you're diagnosed with HIV and you have Kaiser, usually you would see an infectious disease specialist to manage your HIV. Just like if you had seizures, you would see a neurologist, or, if you had a heart attack, you'd see a cardiologist. I think that the idea behind primary care being the place where people get their HIV care comes from the stigma and the isolation that HIV patients experienced within the medical system, where no one wanted to take care of these patients. I mean, that's why you needed HIV clinics in the 80s and the 90s, is that literally patients were being turned away from hospitals because no one wanted to be near them physically. Now there's pros and cons. I think the big advantage is that especially for underserved patients, it's easier to get all your care in one place, because it can be hard to schedule if you don't have a car, if you don't have transportation, if your job doesn't give you time off, or if you don't have a phone. It could be pretty hard to navigate, scheduling all the different visits and keeping everything connected. The downside, though, that we're seeing now is that it's increasingly difficult to find physicians that want to work in a primary care role where they're also going to be doing inpatient infectious disease work. So I think historically, clinics are struggling, primary care HIV clinics are struggling with finding new staff. And so that is one of the reasons why a lot of clinics are transitioning towards a traditional infectious disease as a specialty model. I really hope that providers will continue to come into HIV, because it's an area where these patients, they need so much support. And it's a little bit different than regular primary care in the sense that in an HIV clinic, you're still getting 30-minute visits. You're getting the opportunity to get to know your patients really well and build strong relationships. Whereas I think in the traditional primary care clinics now, it's 15-minute visits, and that includes charting time. So there's very little time with the patients. And so I think, from my perspective, the greatest joy of primary care is getting to know people. The medicine is interesting, but the people are endlessly fascinating. And if you're having that stripped away from your work, I think you lose you burn out and you lose the meaning in your work. And I don't think that happens at our clinic as much because the providers actually really get to know their patients over time.
Yeah, the providers at the PACE clinic that I've come to know somewhat are such kind and compassionate healthcare providers. And you're also then caring for a very diverse patient population here in Santa Clara County. Is the PACE clinic here on the campus at Santa Clara Valley Medical Center the primary or only place that people who are HIV positive can come to receive care in the county?
Yeah, I mean, there are private clinics in the county, but if you're uninsured or if you don't have, or if your HMO doesn't have like an HIV clinic, essentially like most of the options would be like either you go through your insurance to end up getting connected to like a infectious disease clinic through Kaiser or PAMF. But if you don't have insurance to begin with, really the only option is to come to the public health department and through Valley Medical Center. There's just not a lot of places that are taking all these patients or that have the capacity to take on this large number. I'm pretty sure we're the biggest HIV clinic in the county.
Comprehensive, yeah.
Yeah.
As far as that goes, it's great. We care for people who, regardless of insurance status, immigration status, things like that. What are some other things that really set the clinic here apart from others? Like we talked about the kind and compassionate people, but as far as technology goes, or just I guess treatment options and accessibility to care, what are some ways that the PACE ID clinic here at Santa Clara Valley Healthcare really stands out?
So when I started working at PACE 10 years ago, what really I was a student there, but what attracted me to it, I was in an HIV residency and I just started an HIV residency. And so I had to leave that residency to take the position of PACE. And so I was very hesitant to do it because usually you don't leave a residency program. People get upset. And I didn't want to. And when I was talking to them about it, they're like, you should do it. And the reason they kept saying was that PACE is so deeply respected amongst the community and amongst the profession, like with across the board. And I was curious about why that was. And as I talked to people, what I started to realize is that because the clinic has had such a long history and because the population is so underserved, that the clinic itself has been on the cutting edge of HIV medicine for decades, in the sense that for example, if you have all of your patients are very well controlled, they don't have a lot of issues, like they can just stick with first line sort of textbook treatments, you're generally going to do that because there's no reason to try something that's riskier. Whereas at our clinic, we get patients who are in very unique scenarios, where we can't use traditional first line therapies or where the therapies that are available won't work for various psychosocial reasons. And so there's a lot more thinking about what can we do given all the tools that are actually there to help a person right now. What can we come up with that will work for this person? PACE, for example, has been using for years before they were recommended by the guidelines, alternative types of therapies and regimens, combinations of therapies that were being studied but hadn't been recommended by the Department of Health and Human Services yet, because we had patients that were in that situation. So for example, like you have a patient who has a lot of drug resistance, but also has homelessness, struggles with their mental health, struggling with substance abuse. They're not going to take 10 pills a day. It's not even reasonable to ask. I mean, trying to get someone to just be able to pick up medications in all the chaos that they're dealing with is a big ask. So what can you put them on that's once a day, that's just a few pills? What can you use? I think we were able to figure that out of necessity a lot sooner than other clinics were. So for example, right now with injectable treatments, I think the clinic is definitely right there on the cutting edge with, these are therapies that are meant to be used in patients who are perfect patients. They're undetectable. They've never missed visits. And they just don't want to be on pills. But the reality is, of course, that the patients who need something like this the most are the people that absolutely will not take pills or have demonstrated over time that pills are just not going to work for them and are dying of AIDS with little time left. And so I know that in San Francisco, as well as at our clinic, the providers have not been shy to attempt those therapies when it was felt that the potential benefits would outweigh the risks dramatically. And we're always up with the most, cutting edge therapies. So we're looking ahead to see what's going to be coming down the road. Like, should we do this right now, or should we wait, for 2 weeks or a month or a year even to try to get something that's not available yet? Or should we get someone into a clinical trial? So there, I think, medically, the clinic is there. I really don't believe that there's any HIV clinic anywhere in the country that's going to be as able to navigate a super complicated HIV diagnosis. That as infrequent as that may be, we can handle anything at pace.
That's amazing to hear. So you're a leader not only in that destigmatization process, but also in that diverse care that people need often in this county. Is there anything that you'd like to add to that? When I go to that clinic and see the people, it's just a really warm, welcoming, stigma-free environment.
Very welcoming, very diverse. Not only patients, we also have a very diverse group of people caring for the patients. So we try to make the environment as welcoming and accepting and as comfortable as for patients, and we try our best to make them welcome.
Yeah, we have staff that are positive. We have staff of different sexual orientations, different gender orientations. It's the kind of place where, like, if you feel like going into work one day in women's clothing, like, people are very supportive of that. If you feel like you want to, talk about your sex life or whatever, it's a very sex positive. It's a very progressive, fun place to be and work. I think we try to make that not just for our staff, but for our patients. We want people to come there and feel like it's a home.
And specifically, patients actually want to be seen there. They don't want to go anywhere else. And they rely on us because they're very welcomed and they're also very comfortable to be seen at the clinic. So, yeah.
They're just so fun. Patients, Dr. Vogler, one of our doctors today, was telling me about a patient who knitted a blanket for her. And it was telling her that the parts of that blanket are 20 years old.
Oh.
Wow.
I had a patient give me like a little glass car that they etched. It was like this big. I keep it in my room. I think it goes both ways. Like, we love our patients, but they also love us. And that gratitude that we feel from them helps us, work through, not burn out, and stay focused on providing that gratitude back to them. I think we're really fortunate to get that. Like, we have a great community of patients that we work for. They take care of us just as much as we take care of them.
That's incredible. I think everybody I talk to here as part of my job of going around and filming and podcasting is that I hear so often the impact that we are having in the lives of patients, but also in return, the patients are having a huge impact on the way that we do our work here at Santa Clara Valley Healthcare. Along those lines, actually, I wanted to ask you about the way that your clinic operated throughout the COVID-19 pandemic and how you were able to navigate that already on top of the complex work that you're doing on a daily basis.
We remained open and fully functional throughout the pandemic. We were able to care for our existing patients, and also we were able to take on new referral patients. We kind of modified our work a little bit. I think that's when we started doing telehealth by phone or also video visits for patients who don't need to be in clinic to be evaluated. We did a lot of symptom screening, a lot of vaccines, COVID vaccinations. We administered those. We also were in contact with Santa Clara County Housing to find temporary housing for patients who were not able to find housing throughout their isolation period. So, we were really fully functional and available, and patients were able to reach out and access care from us.
Telehealth became a big part of the workflow, I think, everywhere, but especially at PACE. Before the pandemic, there was sort of just like this assumed algorithm of like, you go to your doctor's office, it means you wait in the waiting room, and then you check in, and then you get a nurse takes your vitals, and then you sit in a room, and then a doctor comes and sees you. But if you think about that, and that doesn't include the time that the patient had to take to get ready, to drive or take the bus or whatever to get there, and then after all that to then go and get back, it's like there's a lot of logistical complexity there. So in some cases, I think even now that things are opening up again and that we can see all of our patients in person, telehealth remains a really powerful tool. And now it's something that we're all familiar with using. So I know that, at least with my patients, that we try to do as much as possible through telehealth so that the patients who need to be seen in person don't have to wait as long to get a room, and that they can be seen for longer, and it's easier to schedule them. So, versus someone who really only needs a 5-10 minute phone call, they don't have to spend, 2 hours on each side of that just getting to the clinic and back. They can do that over a break. They could do that at a time that works for them. Whereas the person that really needs all that support, they can go through that little bit of logistical inconvenience to then get like an hour, 2 hours, without any rush. It's sort of like the one size fits all approach doesn't really work, right? Like, some people really need hours of time. Other people, they really only need and want like a few minutes. And that's fine. If there's nothing to do, there's not much to do.
I love to hear that, whether it's through a pandemic or any other challenge that we might face as a community or country or even broader as the world, that we're going to be here to be able to care for the people who really need it, despite whatever else is going on in the world or in their own personal lives as well. And as we move toward, ideally, cures for HIV, things like that, is there anything that you're looking forward to in terms of upcoming research, new therapeutics, anything of that nature that's going to help the community even more who become HIV positive?
Yeah, there's a lot. I mean, so I guess I think what might be most relevant to a lot of our audience is that HIV is viewed as a non-curable disease, but that is a little bit of an oversimplification of what's actually going on. So HIV has been, there have been at least 3 cases of patients who have had HIV, long-standing HIV infections, that have no current evidence of HIV and are viewed as being cured of HIV in the sense that they've been able to stop taking any HIV therapeutic for, in some cases, decades, without any evidence, even in the most invasive possible lab testing, of HIV recurrence. And so what I don't want is people to get the impression that that is readily available or something that is not incredibly unique and special. It's at this point, it's like a research finding. In all of those cases, you have patients who essentially had blood cell cancers and were treated with a life-threatening procedure called a stem cell transplant, which is in and of itself very dangerous. And then to make it even more unusual, the donors that gave stem cells in these cases were individuals who not only matched in terms of safety, which is like finding a needle in a haystack, but were also from part of Africa where there are individuals who have mutations that prevent them from getting HIV. So they're basically immune to HIV. So there's multiple things that are very unlikely. You'd have to have blood cell cancer, be a candidate for a stem cell transplant, find a match in general, and then that match would have to be from a pool of patients who cannot get HIV. So it's like that 1 in a million chance. But that 1 in a million chance does show us that it is curable. If you can completely eliminate HIV from someone's body, it is gone. It's just how to do that in a way that's safe, that doesn't kill the majority of people that go through the procedure, and that's scalable and usable. So there is research going on. There are multiple studies going on in the US looking at HIV cure. And it does seem that, like I'll tell new patients today, that the chance that they're still taking HIV pills every day 20 years down the road is I think, increasingly unlikely. Whether they are completely cured or functionally cured to the point where they don't need to take a pill is looking more and more like a tangible reality. Which even if that's, decades away, I think it's really important because, people are being diagnosed in their 20s. They're looking to live another 60, 70 years. And the message of hope as opposed to a message of fear is really powerful and galvanizing. If you're looking ahead and you're like, I'm going to have to take this pill for the rest of my life and there's no hope of cure, oftentimes the message that would be used to get people to do that is fear. If you don't do this, something bad is going to happen. But fear isn't a powerful motivator. Once people realize that they're okay, fear just becomes, something that makes you upset. It doesn't really motivate you to actually do anything positive for yourself. Versus the reality is that if you take HIV pills every day and you're positive, that you are maximizing your chance for HIV cure 20 years from now. That you're the person that is going to be easy to cure versus someone who's going to be extremely difficult to cure because the burden of infection will be that much less. So on a broad scale, I think that's the biggest thing that's looking like is developing in HIV. From a traditional take medications to treat this disease, the focus has really been on, we have a lot of great pills that you need to take once a day, but you have to take them every day. What are ways that we can help people that don't require them to be tethered to like a daily therapy or a pill? And so injections are getting a lot of attention. The first set of injections we have are great. They're once a month, but they have major downsides. You have to go to a clinic to get them. It's not like something you can do yourself. It's not a painless injection. They can fail and lead to resistance if you miss the shots. So, they're not ideal. There is an injection in development that we expect. It's a drug that's called a capsid inhibitor, or lenacapavir, which is being developed. That drug is a once every 6-month shot that is much more flexible. Just being able to get something once every 6 months, it opens up a lot of interesting possibilities. We have yet to see how the FDA will approve it. Most likely it will be in combination with other medications, so it's not a totally like oral drug-sparing regimen. But you could imagine scenarios where it could be really helpful to people who have struggled to succeed with just pills. And an every 6-month dosing interval is really liberating for a lot of people. So I think that's the most exciting clinical development that's on the horizon. But there's other therapies that are being developed that are more traditional, daily pills. There's always new HIV drugs in the pipeline. And then, of course, probably the next area where there's the most important developments is prevention. We have injectable treatments and pills for prevention that are extremely effective, but there's still room for improvement. So there's development and work on creating, say, like an implant, much like you have for women who are trying to prevent pregnancy, or for individuals who are trying to prevent pregnancy. Implantable HIV preventative therapies could be really helpful. Someone can have this implanted when they feel that they're at risk and continue it, and then if they feel like they're no longer at risk, they could have it removed. So I think that would be my hope. There's also a vaginal gel that's being developed, which could be really useful. There's not as many treatment options for women as there are for cis women, as there are for cis men and trans women.
And in your experience too, as you see these new technologies being developed, and ideally, in a perfect world, we eventually see something that, where you said you don't have to take a medication every day. Compared to like 20, 30 years ago, are you seeing this technology developed at a much greater rate? And do you just foresee that happening even more?
Actually, I think the rate of new focus and development in HIV is certainly reached. It's certainly past the inflection point. It's not plateaued yet, but it's not like it was, in the 90s when drug companies were pouring money into HIV and the government was pouring money into HIV. I think the focus on prevention and isn't going so much towards therapeutics as it is towards addressing that problem we talked about earlier in the interview, which is linkage, getting people into care. We have the tools we need, by and large. What we don't have is the structures to get everyone comfortable enough and giving them access to the care that they need. So there's a lot more, I think, money going into that realm of it, the psychosocial realm of it, than there is into like, let's get a whole new range of, tools to fight the infection. Versus in the 90s, the therapies were terrible by and large, right? I mean, people were taking, in some cases, drugs 5 times a day. They were getting kidney stones and horrible diarrhea, and in many cases, severe problems from the medications, heart disease, liver disease. Now we're dealing with therapies that are, essentially the long-term toxicities are quite mild. For example, much less than, say, you would get with, say, birth control in women, or taking a daily ibuprofen. Ibuprofen, birth control, they're much more toxic than like any HIV regimen that we would use today.
There was a question that I wanted to ask you both, and it's something that I've heard in the media from CDC, and it's called U equals U. Can you tell us what that means?
So U equals U it's a really powerful message. It means undetectable equals untransmissible. This is something that, at least at Pace Clinic, we've been practicing with this message the entire time I've been there. But it only in the last, I think, 4 years has been endorsed by the CDC. What it means to a patient is that if your virus is unmeasurable on a blood test, meaning that if you have your blood drawn and the viral level or the amount of the virus in the blood is less than what that test can measure, that there's no chance that you can spread the infection. Whether you have sex with or without a condom, whether you share needles, that there isn't any way that HIV would be transmitted. One caveat is that for women who are pregnant and nursing, it's not clear whether you could spread it through nursing. But for the vast majority of situations that you could think of, it essentially means that you're not contagious anymore, which for patients is very liberating, right? Because it means that they can have sex without having to feel terrified that they're going to spread this virus, which, as you can imagine, is one of the primary concerns that people have when they're HIV positive is, how's this going to affect my sex life? The other end of it is that people have to be careful to make sure that they're actually undetectable. It's important to realize that the only way to know whether you're undetectable is to do a blood test. So usually what I'll tell patients is, once you start on treatment, typically in about 70% of cases, you'll be undetectable within a month. But you won't know that until you actually get a blood test done to repeat it. And then once you have one test that shows it's negative, we just recommend doing a second one, usually like a month to 3 months later, to confirm it. And if that looks undetectable and you haven't missed any doses, you can be 100% sure that you're not contagious. The other, I think, really important point here is that HIV can't be transmitted through like non-sexual means, or other than sharing needles. So for example, patients will often ask, like, am I going to transmit this to my family members just from being around them, from cooking with them, from like sharing a bathroom, from sharing a drink? Is that a problem? And the answer is no. Like, regardless of what your HIV state is, like whether you're on treatment, not on treatment, initially in the infection or later on in the infection, HIV is not spread through kissing. It's not spread through just normal, regular interactions. It is a completely not contagious in that way. There has to be prolonged sexual contact or sharing of needles to really have any significant risk. The U = U just gives you another level of protection. Even if you're not using condoms, you won't pass HIV to somebody else.
Do people need to be worried at all that they're undetectable one day and then tomorrow they're not? How long does that label kind of last? Or you mentioned taking your medication regularly. Does that help you to avoid that day to day?
Yeah, so unless you're in a very unique situation, like unless you hear otherwise from your medical provider, essentially, if you're on HIV treatment and you're undetectable already and you never miss doses, you will stay undetectable. There isn't any chance of breakthrough. The medications don't fail if you're already undetectable and you don't have any substantial resistance to them. Even like a single missed dose, you're not likely to see any sort of viral breakthrough in those kind of situations. There are situations where patients are on regimens that don't work fully for them, but those are usually where a patient has extensive resistance, which typically comes from individuals who have been diagnosed for a long time and have been on and off therapies, rather than individuals who are entering into HIV right now without having been exposed to medications. So, and a lot of times it's hard for people to really absorb that, but it really truly means that you're not contagious. I'll give you an example. So like even before the CDC endorsed the U = U message, if you look at how they would recommend, say, giving advice to an individual who wants to conceive, like a male partner who's positive, they want to conceive and have a child with a female partner who's negative. How can they do that without the child or the mother getting HIV? The advice for the entire time I've practiced has been to conceive naturally. Just make sure that the patient who is positive is undetectable. So even in that like highest stakes kind of scenario, the advice from the CDC has been very clear that you're not at risk for HIV transmission. You're not at risk for getting HIV if your partner is undetectable. So I think what changed and where the CDC decided to endorse the message broadly was data from HIV prevention trials that showed very conclusively that individuals who are in couples where one is positive and one is negative, that when they are offered preventative therapies, the individuals who are negative, they're not getting HIV from their positive partner. When you look at the infections that occurred in negative individuals in prevention studies, the cases were all from other individuals. They weren't from their undetectable partners. So essentially, if you're undetectable, you're not going to spread the infection. But your responsibility then is to make sure that you're not missing doses and you're sure you're undetectable. And so if you're not sure, the only way is to do a blood test to, kind of convince yourself. It's also a good time to get other STD screening done. So, especially if you're having sex without a condom regularly, taking HIV meds does nothing to prevent you from getting syphilis, Hep C, Hep B, gonorrhea, chlamydia, herpes, warts, anything you can think of. So STD testing is really important, and that's really the best way to maintain your sexual health, right? Is to just get regular STD screening.
Absolutely. And it sounds like another podcast we will have to do for sure about all of those things too. But I just really appreciate you both coming on the beat today to talk about the infinitely important work that you were doing over there at the PACE ID clinic in regards to caring for oftentimes vulnerable patients in our county. And the last question that I want to hear from you both is, you must feel a great fulfillment in the work that you're doing on a daily basis. Can you tell us why it is that you continue to do what you do, and maybe your favorite part of your work?
It's just the people and the teaching. I mean, initially, I think it was a mixture of I was really fascinated by the medicine, and I liked the concept of I liked all the struggle that these patients were going through. But as time has gone on, the medicine is fascinating, but it's the people. I mean, it's the patients, it's the other people in the clinic that I work with, it's the students that I get. That to me, every person that I interact with, whether it's the person I'm taking care of, the doctor that I'm consulting with, or the outreach staff, the front desk staff, the mental health staff, Martha, they're all just so fun. I mean, I really look forward to working every day. It's like going to hang out with your friends and doing something meaningful at the same time. So to me, it's like a dream job in that way. And I feel like every day there's new fun things, and there's also new challenges. It's never boring. It's very, very exciting. Yeah. It's very satisfying. For me, I think it's a very satisfying career. I can see the impact of what I'm doing. I feel like I'm doing something positive with my life. I feel like I've had a lot of privilege and a lot of support, a lot of second chances. I don't think I would be where I am if not for all the support that I've been given. So I feel like it's critical for my own well-being and meaning to know that I'm doing something with that privilege to help other people who haven't been so privileged.
Martha, I'm sure you must share some similar sentiments.
I share the same sentiments. And like Rajat said, what stood out from what Rajat said is the privilege. So I've always felt that we're working with patients, whether at PACE clinic or even inpatient. I've felt that the job that I do as a nurse is a privilege, and the chance to really make a difference in another person's life, and also to be able to make a human connection and really impact someone else's life, and also learn from their experience as well. So it goes, both ways. And so for me, yes, I love the clinic, I love the patients, and I love to see the changes that in the patients that I love to see changes in people, the way they're impacted by the care we provide. Staff is great. I think just the privilege and the ability to make a difference is, might sound like a cliche, but it's true.
That is excellent. Yeah. And I just thank you both so much for not only the work that you're doing on a daily basis, but for coming on the podcast today to share about it as well. And it's just so amazing to hear these wonderful stories, and also the direction in which you are taking healthcare here at Santa Clara Valley Healthcare. Please come back anytime. We'd love to talk more about all of the great things that you're doing.
Thanks, Nick.